Good afternoon, and thank you for joining webinar 4 of a 4-part webinar series titled Self-Testing Strategies for HIV Testing and PrEP. My name is Kendrell Taylor. I'm a manager on the prevention team here at NASTAD. This series aims to share models and innovations from health departments about the implementation of a wide range of self-testing programs. This series has addressed public health implementation models, which include outsourcing self-testing to a commercial vendor, delivering services through a current public health infrastructure, including CBOs, and state health labs, or a mix of both. In this particular section, we will provide an overview of the self-testing toolkit NASTAD in the collaboration with the Association for Public Health Laboratories developed to describe considerations for evaluating test performance and provide an example of how one jurisdiction has implemented self-testing strategies to advance public health priorities, such as the implementation of PrEP, integration of services, addressing health equity, and addressing gaps in services during the COVID-19 pandemic. I am joined by colleagues from NASTAD, the Association for Public Health Laboratories, the Virginia Division of Consolidated Laboratory Services, and the Texas Department of State Health Services, who will guide the discussions and answer questions. This webinar will be recorded and posted for future access. We also have a chat function available and encourage you to use this during the session for any questions or comments during the webinar. At the end, we will have about 15 minutes to delve into some questions and have a live discussion. Again, questions asked during this webinar will be answered along with any resources and will be posted for future access. Before we get started, we have our project officer from CDC, Maria E. Alvarez, who will say a few words about our partnership. Maria?
Thank you, Kendrell. Can you hear me?
Yes, loud and clear.
Excellent. Well, thank you. Good day, colleagues and partners. My name is Maria E. Alvarez, and on behalf of CDC's Division of HIV Prevention Program Branch, it's my privilege once again, as the Capacity Building and Technical Assistance Lead, to welcome you all to today's webinar. Thank you for joining us today, and a special thank you for participating throughout our 4-part technical assistance series. We really appreciate you taking time out to attend. Thank you also to all of today's presenters. We are confident this will be another outstanding webinar. Also, a special thank you to NASTAD for their ongoing efforts in planning and hosting these important state-of-the-art webinars, which continue to demonstrate our collaborative commitment to the HIV prevention workforce, partners, and communities. In addition, we encourage you to visit our CDC PS 19-1906 website to read and review copies of the updated local ending the HIV epidemic plans. The plans reflect the innovative, community-driven solutions that are really at the heart of your EHE local plans and initiative overall. These tailored plans highlight key strategies and they address the unique needs in your communities. CDC remains committed to our ongoing partnership and the provision of technical assistance services. If you have missed any of the past TA webinars, please visit NASTAD's website to access recording and slide decks. Thank you again for your participation in today's webinar and for your active efforts to end the HIV epidemic together. NASTAD, back to you. Thank you.
Great. Thank you, Maria, for those words. For the remaining portion of the webinar today, I will be handing it over to my colleague, Lisa Randall, who will lead us through the first presentation. Lisa?
Thanks so much, Kendrell. I appreciate the handoff, and thank you for the reminder that I'm once again muted as I begin to speak. Good afternoon. I'm Lisa Randall. I'm a consultant with NASTAD, and I'm really pleased to be here with you this afternoon to present a toolkit which has been under development for a few months in collaboration with the Association of Public Health Laboratories. Just to begin with, self-tests for HIV, viral hepatitis, and sexually transmitted infections are increasingly available and can really be important tools in providing greater access to testing, linkage to treatment, and prevention service. This is, of course, especially relevant in the midst of the ongoing pandemic, but I think that we all have a sense that it is going to be continue to be so in the after times, as I like to think of them. Next slide, please. So as much as self-testing is a tool for consumers to control and manage their own health, self-testing can also be a tool for public health to facilitate equitable access to testing resources and to advance public health priorities and programmatic objectives. Next slide, please. So what's in the toolkit? NASTAD and APHL have developed this toolkit to help health departments and public health laboratories, as well as their community partners, decide whether and how to incorporate self-testing for HIV, viral hepatitis, and STIs in their overall testing strategy. What you see here on the screen now is an overview of the key components of the toolkit. There's also a companion set of case studies of selected health department supported testing programs. Some of these programs have been showcased in previous webinars in this series. The case studies provide detail about the self-testing models employed by the representative health departments. It includes operational details and recruitment strategies, along with lessons learned that other health departments might find helpful as they consider their own self-testing activities. Next slide, please. So self-testing is not one thing. There are a number of models of self-testing which vary based on where and how testing resources are accessed or the point of entry. Some points of entry include involvement of a healthcare providers, others do not. Self-testing models also vary based on sample collection and testing methods, or how and by whom samples are collected, tested, and results delivered. We were really intentional in defining self-testing this way because we recognize that various stakeholders have various understandings about what is encompassed by this term self-testing. And it can and has led to a little bit of confusion about what exactly a self-testing strategy entails. And so in this toolkit, specifically and increasingly in some of our conversations with health departments, self-testing is a shorthand for various models of testing. Next slide, please. Whether you're aware of it or not, there are already multiple options for self-testing being used right now in your jurisdictions. And the availability and use of self-testing options is growing rapidly. Some of this is happening specifically in the context of the pandemic and the increased production of COVID tests, but some of it is also sort of a natural evolution of testing technologies. As public health professionals, we really need to be aware of these options, including the implication that the various models have for consumers in terms of accurate knowledge of their infection status, access to treatment, or linkage with prevention resources. And for public health, it's important for us to be aware of what's going on in our jurisdictions outside of what we may manage or support, to understand the extent to which these related activities may be consistent with our public health priorities and program objectives, and the extent to which they impact upon, for example, surveillance reporting. The various models of self-testing as they're presented in the toolkit are represented on this in this table on the slide that you're viewing right now. As you can see, there's a bunch of different options for consumers to obtain testing for HIV, viral hepatitis, and STI. At the far upper left corner, we have a model which is entirely consumer controlled, the direct access model. And that entails an individual acquiring the test, collecting the sample, doing the test, and reading the results all directly within their control. At the far lower right of the table, you'll see something that is much closer to a traditional healthcare encounter. A consumer engages a healthcare provider to facilitate testing. And testing is actually performed in a lab, and results are mediated by a consumer. Now, health departments can and are involved in the various models that are represented on this table, and we've included examples of both commercially available tests and testing services, as well as health department models on this table. Next slide, please. The toolkit also includes a table in Appendix A, and that's what you're viewing now on the screen, that summarizes some of the commercially available tests and testing services. Included in this table are the assays that are available, along with the sample collection methods that may be available, as well as the cost to consumers. These are approximated. Just to be clear that this table is not exhaustive of all of the commercially available tests or testing services, and the particular services represented on this table may or may not be available to consumers in your jurisdiction. Next slide, please. So there are many policy, technological, and operational considerations that really need to be looked at and examined by anyone thinking about whether they should implement a self-testing program and how they should go about doing so. In the toolkit, we discuss factors that health departments are encouraged to evaluate as you consider self-testing. And we've organized these factors into 3 domains, which you see here on the slide. And with each of these domains, we address some of the drawbacks and benefits associated with each of those domains. So self-testing can be viewed as a tool to improve access to testing and to advance program objectives, like expanding uptake of PrEP, integrating testing across infections, and perhaps addressing stigma. But it may not be the best or most appropriate testing strategy for all populations, for all individuals, or for all health departments. Certain models of testing, self-testing, may be more relevant or feasible than others for a given population, individual, or health department, and we are encouraging you to consider these. As a strategy, self-testing should match the needs of various populations or communities in your jurisdiction. Some communities may be better served by a particular model of self-testing, such as if they have a high prevalence of co-infection with HIV and syphilis, or if they have a high likelihood of acute HIV infection, for example. Self-testing should also match the needs, priorities, and abilities and preferences of individuals that are actually using the self-testing strategy. You want a strategy that not only provides access and encourages testing, but which is also right for the testing needs, going back again to some of those examples of co-infection or recency of exposure. And they also have to be feasible for individuals to use, not only in terms of collecting samples and performing tests, but also to facilitating their engagement with treatment and prevention services. Finally, self-testing should also match health department capacity. The level of resources and capacity required to implement and manage self-testing depends on how the self-testing program is going to be implemented. How much are you doing centrally, or can you do centrally within your state or your local health department? How much are you going to do in-house versus perhaps a vendor or vendors? How much can you or should you do, again, from a central location versus through county health departments or through individual community-based organizations? Next slide, please. We include in the toolkit this strategy, or this table that describes the benefits and the drawbacks, some that I have just described as examples. And in the terms of the 3 domains that I mentioned, the population, the individual, and the programmatic level. What you see on your screen right now is a snapshot from the first portion of the table, where we summarize the factors and summarize some of the benefits and the drawbacks of each of those factors. And so this is just a sample of a larger table. The toolkit also includes detailed recommendations and tips illustrated by real-world examples drawn from some of your colleagues in other jurisdictions of how health department can address some of these population, individual, and programmatic level factors as they're planning to implement a self-testing program. We're not going to go over those in detail today because it constitutes the bulk of the toolkit. But we encourage you, once you have an opportunity to actually look at the toolkit, to look at those in more detail, because they provide some really, I think, good examples and scenarios that you might want to consider. Next slide, please. Regardless of the specific self-testing strategy used within your health department or by your community partners, test performance is critical. And because they possess valuable expertise and expertise that some of us who work on the program side more as our primary responsibilities, our colleagues in public health laboratories can and should be partners in the process of evaluating and planning self-testing programs. And so to help us learn more about evaluating test performance and about the role of public health laboratories in supporting implementation of self-testing programs, I'm going to turn things over to my colleague, Dr. Ann Gaynor from the Association of Public Health Laboratories. Thanks so much.
Thanks, Lisa. You can hear me?
Yes.
Okay. So as Lisa mentioned, I'm going to highlight a few of the sort of laboratory aspects of the toolkit, and we'll get into some more detail on some of this in the first presentation. So everyone's here today because you want to know how to ensure quality testing and testing services. And that's true not only for you all on the programmatic side, but as well on the public health laboratory side. The other sort of guiding principle I want folks to keep in mind is that all laboratories, whether they're public health, commercial, clinical, et cetera, that perform testing for patients must follow the same rules. And so therefore your public health laboratories are following the same rules that commercial entities are. So they serve as a good sort of, we'll get into their roles in just a minute. But so here, what I want to highlight just quickly, Lisa had mentioned at the beginning, sort of these different types of self-testing strategies, but the guiding principle I want you to remember here today is that there is actually only one FDA approved or cleared self-collection device or test, and that is the OraQuick in-home HIV test. So that is the only one that has gone through FDA review. All other tests or testing services that are using samples that have been self-collected in a non-clinical setting are considered laboratory developed tests. And you'll hear more about those terminologies in just a moment from Dr. Freeman. So again, the last thing to keep in mind here is that any laboratory that's accepting and testing self-collected samples that are not included in the FDA approved or cleared method must have performed a validation that meets the requirements of the regulatory agency that allows them to perform clinical testing. The exception here is that there are some self-collected vaginal samples that are included in the chlamydia, gonorrhea, nucleic acid tests, but those are self-collected in a clinical setting. So next slide. So the role of the public health laboratory. So I sort of envision this in two ways. There's the first role and the second role. So the first major role is that of the subject matter expert / consultant. So if your program is considering using a commercial product, a third-party company, an online testing service, whatever you want to call it, for any aspect of your self-testing strategy, the laboratory scientists in your public health laboratory can help you review the available testing options, ensure that the products that you're considering meet your needs, and that the testing is being performed to meet quality standards. So this could ensure ensuring that the services using are offering the best test and or specimen type for your need. For example, if you need to target your population for acute HIV testing, an oral fluid test is not ideal. It's not as sensitive than a blood-based test. Alternatively, if you're looking to try to diagnose HIV, HCV, syphilis, one of these pathogens that requires a multi-test algorithm, you need to make sure that confirmatory testing is included in how you're offering your strategy, since many of these services are just screening options. Alternatively, it could ensure making sure that your chlamydia, gonorrhea testing, that you're testing all 3 sites, that you're using optimal specimen types, et cetera. The public health scientists can also help ensure that specimen collection and transport has been appropriately validated to ensure the integrity of those samples. So you're sending home a self-collection kit or they're getting mailed one. We need to make sure it's coming back to the laboratory in a way that actually that sample can be tested. Has it been subjected to the potential things that might happen in real life? Does it stand the test of being in the back of a car for a few days in Texas or in Florida, very hot, or in a very cold temperature? Can it freeze, et cetera? So you want to make sure those things have been addressed, and your public health lab folks can help you look at that. And lastly, and the reason they can help you with this is that per regulatory requirements for laboratories, whether that's CLIA or CAP, laboratories must provide information on the test method and the performance data upon request. So you can ask for this type of data, and your public health laboratory can help you evaluate it, since you may not be as familiar with it and it's something that they are used to looking at. So the second role is they could serve as the lab performing the testing. So if you want to go to the next slide, Kendra. So these are some considerations that we put together, and there's a little bit more detail, obviously, in the toolkit, but just some major considerations for public health laboratories. What is the capacity of the public health lab? Have they already validated self-collected specimens in a clinic? So it would just be looking at the self-collection in a home setting. Do they need to add a new specimen type, such as dried blood spot or microtainer blood? So what all sort of needs to be done to address the needs of your programmatic approach? And how do you work together to ensure that everyone feels confident at the end of the day that the shipping and transport of those specimens makes them still useful for testing? The second bullet point here is sort of the capacity for collection kit assembly and distribution. So how do you get those kits out to your population? Is that the public health lab that's going to help with that? Is the health department's going to work together? Is that a third party? Sort of who's doing that sort of piece of getting all the puzzle pieces together, from the materials for the actual collection to the instructions and any other material that would be needed. And then the last part is reporting, and this is certainly not minor, but how is reporting going to happen? Does the public health laboratory have the capacity to report back to the consumer? Is that what you want? How is a telehealth provider engaged, if that's part of it? So making sure that that reporting piece is really wrapped up. Next slide. So that sort of summarizes, sorry, I didn't transition properly, but summarizes the laboratory aspects that I will cover today. There is more detail in the toolkit, and you will hear a little bit more about the validation aspects from our next speaker. The last piece I want to highlight from the toolkit itself is there is this very nice tip sheet at the very end of the toolkit, and this really summarizes some of the key considerations in a nice one-page printable thing that you can keep with you as sort of a checklist reminder of how you addressed all the things that you might want to consider. And if you go to the next slide, this is just a summary of those key considerations, making sure, as Lisa mentioned, that your strategy aligns with your needs. Are you addressing all of the population incidence, prevalence, comorbidity, as well as client needs? Are you assuring quality testing? And that doesn't just start with the testing, that's before this person gets the sample collection kit, as well as all the way through the testing and reporting pieces as well. So we call that the pre-analytical, the analytical, and the post-analytical phases. So you want to make sure all of that is done well. You want to make sure you can facilitate disease surveillance if you're doing in-home testing, making sure you're getting those results so you know what's going on. Appropriate monitoring and evaluation to know how your system is actually performing once you've rolled out a system. And then feasibility. Lisa talked on about the public health, or the health department resource and capacity. I talked a little about the public health lab. The other part is legal and regulatory. So one thing just to keep in mind is that not all states allow for direct access testing. So making sure you know the regulatory environment that you are operating in. So with that, next slide. So this is Lisa and I's contact information. We are also continuing to work on additional tools and resources for health departments and public health laboratories as they navigate selection and implementation of self-testing strategies and in support of elimination strategies for HIV and HCV. So if you have any questions today or down the road, we're happy to hear from you, or any suggestions for things that would be helpful. And with that, I would like to, next slide, introduce our next speaker, Dr. Marilyn Bibbs Freeman. She's the Deputy Director of the Division of Consolidated Laboratory Services in Virginia and a member of APHL's Sexually Transmitted Disease Committee, amongst many other talents. So thank you, Marilyn, and take it away.
Thank you so much. Great presentation. I think that Dr. Randall and Dr. Gaynor have done an excellent job at explaining what all of the benefits are to self-testing. And I'm hoping that my presentation now will give you some tips and things to think about when you think about the quality of the self-testing, regardless of the strategy that you use, whether you're going to self-collect it or whether it will be clinician mediated or possibly tested at home or tested in the lab. So next slide, please. Hopefully by the end of the presentation, we'll be able to discuss verification and validation and have some level of understanding of that. Some verification and validation terminology. I will just disclaim that this is not an exhaustive list of terminology. It really will be a high-level overview of the verification and validation process. And then finally, I'd like to point out some quality and process considerations for self-collection and/or self-testing. Next slide, please. So just some general definitions, and I won't read these to you, but I'd like to instead give you an example. So when a manufacturer is first conceiving a concept for a test kit, the first thing they need to do is validate it. They have to determine the performance characteristics of this expected device prior to getting approval from the Food and Drug Administration. What they are doing prior to it being able to be purchased in the US is called validation. They've looked at all of the research associated with what they are proposing. They have tested it in-house, tested it in various conditions, and also done quite a bit of research on the best way to market it such that FDA would be willing to approve it. What we're doing once we order these kits is a verification. We are verifying that in our hands in a laboratory setting or whatever setting it may be used in, it is performing as expected. It's performing in the way that was initially validated by the manufacturer. I'd like to also highlight that a verification is appropriate for FDA approved methods. However, if we are going to use a non-FDA approved method, or we're going to use a method that is being used outside of its normal approved usage, or what we consider to be off-label, we will have to do additional steps, and that kind of moves us into a validation standpoint. So just to summarize, a verification in a laboratory is what we are going to do to ensure that the device works as the manner it's expected when it was sent to us and by the manufacturer. The manufacturer of the device is going to do a validation, or if a laboratory plans to use a device off-label, a validation will also have to be completed. Next slide. Must I verify and validate? In this particular situation, the answer is yes. We all know that there are quite a few waived devices that are available on the market today for various reasons. However, none of those devices fit into the realm of what we're talking about here as it relates to STI, self-testing, and self-collection. We must validate and verify in order to establish that the processes for collection are appropriate and work as intended, that their different sample types can be used. A sample type from a rectum may not perform in the same manner as a sample from a throat. So you would have to test those two different sites to be sure that they work as expected when you are using the test for STI testing. The media that you're using to collect the sample in, or if no media is being used at all, these are the considerations that need to be thought about prior to performing the testing. When we're talking about self-testing, self-collection, and potentially shipping to a laboratory to perform off-site, we then need to kind of look at the shipping process, as well as the testing process, and then each organism or target that you plan to test with. So if you've validated a test for syphilis, we still need to go back and validate the test for gonorrhea. So one validation does not necessarily mean you're good to go with everything. You need to test it in the various different configurations it could potentially be used in, and document it to ensure that you are receiving test results that are of known quality. Next slide, please. So the next slide basically says who. So the easiest answer to give you is it's the law. The Clinical Laboratory Improvement Amendments, most recently published in 2004, can be found in the Federal Register at 493/1253, specifically speaking of performance verification requirements. And so laboratories that are considered to be high complexity laboratories and able to perform this type of testing will need to be certified by the Clinical Laboratory Improvement Amendment under the Center for Medicare and Medicaid Services. Another option does exist. CLIA and CMS will give authority to different organizations in order to establish whether or not a particular laboratory is capable of producing high quality laboratory testing results. I did only list one here because it is by far the most popular, and that is the College of American Pathologists, also called CAP, that will actually come in and do inspections in lieu of the CMS and CLIA regulations, but they've been given that authority to do so. And there are others. In the references to this particular presentation, you will find a list of other organizations that are allowed to perform inspections for laboratories that perform this type of testing. Next slide, please. So here are some very quick verification and validation definitions, the ones that will be related to the law, the CLIA law, and are necessary to establish performance of a test system or kit within the hands of a particular laboratory. So the first is accuracy. And accuracy, the easiest way to explain it is you have a target, and how good is your test at meeting that target? To what degree does the result of the measurement or the calculation or specification conform to the correct value or the standard? So if I have a test A with A performance, do I get A every time I run this test? Another parameter that's needed for verification and validation is precision. And precision defines how close two or more measurements are to each other, regardless of whether they are accurate or not. So it's possible to have very precise measurements that are inaccurate, but ideally when you're running a test and verifying it, you want to have good accuracy as well as precision. Another way to think about precision is if I repeat this test over and over and over again, do I get the same results? If someone else comes and repeats the test behind me, do I get the same results? And so that is going to be the hallmark of a test system that is precise. The reportable range really just covers the span of test result values over which the laboratory can establish or verify the accuracy of an instrument. So some of the instruments that we have will say, this is good to this level. And so we have to establish that we can get to that level as well before we report out results. And then finally, the reference range, which the easiest way to consider this is what would be normally expected in a population of individuals. To relate this directly to sexually transmitted infections is that normally in the population, the expectation is that people do not have a sexually transmitted infection. And so in this particular case, the normal range would be not infected. A range that indicates a result that is out of spec or positive would be a non-expected result. Next slide. A few other definitions that will be necessary in understanding how to verify and validate a test is analytic sensitivity, when particularly you are using a test off-label. And so we talked a little bit about that earlier in the presentation. When a manufacturer actually performs validation testing, they will establish the analytic sensitivity as well as the analytic specificity of the test. If we have chosen to use a test off-label, which means outside of the parameters that the FDA has approved, we may also or will also need to perform analytic sensitivity and analytic specificity. And so analytic sensitivity really refers to the lowest concentration or amount of an analyte that can be measured and distinguished from something that we call a blank. And a blank is just basically a sample that does not have the target of interest. A lot of times analytic sensitivity is considered a limit of detection, how low of the organism is expected to create a positive result. A lot of times if we don't have a test that is quantitative, we don't really need analytic sensitivity because we're not measuring a quantitative value. Analytic specificity really talks about the ability of an instrument or test system to measure the intended organism or substance rather than others. And so when we look at analytic specificity, the things that we're thinking about are there interfering substances that prevent me from getting the correct result when I use this test system? Does this particular test system potentially cross-react with other organisms to give me a false positive result? So those are the things that we kind of want to look at. I've also thrown in here, and while they're not required by law, diagnostic or clinical sensitivity and diagnostic or clinical specificity can also be evaluated. And these are primarily used for qualitative tests that give you a yes, it's there, and no, it's not. And the clinical sensitivity is the ability of a test to correctly detect an analyte when it's there. Likewise, or conversely, clinical specificity is the ability of a test to detect the absence of an analyte when it is not present. So clinical sensitivity, if it's there, can I tell you it's there? On the other hand, clinical specificity, if it's not there, does my test accurately tell me that it's not there? Next slide, please. So how? And basically, this is a table to kind of quickly outline what we've just gone over in the definitions. But if you have an FDA test that has not been modified, the parameters that you need to cover are accuracy, precision, reportable range, and reference range. In addition to that, the regulation also indicates that if you are using a laboratory information management system, you have to ensure that it is tested appropriately and gives the right results or transmits the right results per the way that you report them. And so we don't want to report a syphilis test as positive, but then there be an error in our LIS system and it accidentally be reported as negative. If for whatever reason you have modified an FDA approved test, or you are using an FDA approved test that is being used off label, then you add in analytical sensitivity and analytical specificity in addition to the ones that I've already mentioned. At this time, it's important to recognize that nearly all self-testing is considered a laboratory developed test. And so that will put you squarely in column 2 of FDA modified or laboratory developed test, LDT. Currently, FDA approves methods that start with the validation process at the self-collection step and continues through the final interpretation and reporting. And so basically from conception to birth of the testing process, from the time it is collected until the final result has been received, has that entire process been verified or validated appropriately to ensure that you're getting high quality diagnostic testing results. Currently, only OraQuick for HIV is FDA approved for self-testing and no other sexually transmitted infections. And then there's also limited clinician mediated, which means a clinician is observing the collection or facilitating the collection of the device for sexually transmitted infections. Next slide, please. So here we kind of get into some of the things that you should think about when trying to evaluate whether or not the quality of a self-testing, self-collection system is going to be appropriate for your usage at your different health departments or organizations. And what we're covering here in the kit preparation piece is what we consider to be pre-analytical testing. And this is everything that happens prior to the test actually being run and performed. And so if you are choosing to do kit preparation in-house, some of the things you want to ensure are working appropriately are the procurement process and how you purchase your materials. The materials that are being used, are they high quality and well documented and traceable? The inventory space that you have available in order to do kit preparation. Does your inventory system have a tracking ability and traceability portion to allow you to manage each of the components? And by components, I mean the collection device, the shipper that you're going to send out to the customer to use, the collection form. If there's a swab available, do you have swabs that are in date and that can be monitored and pulled from the shelf if they've expired and things like that? What are your internal QA or quality assurance procedures in-house if you do plan on preparing the kits yourself? If you're using an external vendor, does this vendor offer a questionnaire to your customers to ensure that the customer is receiving the right type of self-collection kit? Is this vendor ISO accredited? And so you'll hear that a little bit. It's the International Organization of Standards, and I know that it's not iOS, it is actually called ISO 9001. And basically, this is a standard that establishes the quality of a manufacturer to prepare a kit and distribute it and send it out. ISO is not necessarily always required, but it's nice to see and nice to have because you have an additional assurance that the processes of the particular vendor have been established and are being monitored. The fulfillment practices of the external vendor. How long does it take them to fulfill these orders when they come in? Can they ship them out within 24 hours? How long are the kits good for? Do we have time? Is this something that needs to be returned quickly? These are all things that to consider in kit preparation. One other thing that I'd like to kind of mention here, if you are going to use an external vendor, it's always fair to ask them for references. Is there someone else that's using your kit that I can call that can attest to the quality of your kit and also the performance of your services prior to me engaging with you and establishing a contract? Regardless of whether the kits are prepared in-house or by the vendor, you probably need to establish who is allowed to order the test. Does it need to be a clinician? Can it be the end user? Establish the ordering process, the storage requirements of the kit, as well as the collection device, appropriate shipping containers, tracking mechanisms, shelf life. Shelf life refers to once something is purchased, how long is it good for? Labeling, expiration dates, are they clear? Are they easy to understand? Does the company or do you provide phone support so that if someone is having problems retrieving a kit or issues with the collection, can they pick up the phone and call? Is there online support or computer support? Are they monitoring the clock? If a kit needs to be back within a defined period of time, is this company monitoring that for you, or is that something that you're going to have to monitor yourself? Next slide. So self-collection, again, is part of the pre-analytical process because this is occurring prior to the test being performed. And I think it's really just good to emphasize here with this slide and the previous slide is that sample is only as good as the collection that's performed, and appropriate shipping and handling can affect your results. So whether the self-collection is provider or clinician mediated or self-collected in totality by the user, things you want to consider are there training videos available that will guide the user through the collection process? What sample types are appropriate? Have we ordered the kit that is appropriate for the sample type in which you intend to use it for? The environmental conditions, not only for collecting the sample, but also shipping it back. What temperature can the sample be shipped back at? Does humidity affect the samples? When you have things like blood spots that may potentially be collected, blood spots can be impacted in a negative manner by humidity. The humidity will actually make your filter cards wet or moist. And will that moisture now affect the test results that will subsequently be run? The collection location. Is it possible to do this at home, or is it going to need to be done in a controlled setting or with assistance? The instructions, whether it be for collection, packaging, shipping, or reporting, are they clear? Are they easy to understand? Are they available in multiple languages? Sample tracking, if tested in the lab, are you tracking the sample from the time that the collection kit is received by the user to the time that it is received in your laboratory? Are there clear rejection criteria? If a sample doesn't arrive in the laboratory by the time that it needs to be tested, have you defined that that is a rejection criteria that will need to be used in order to exclude those samples from testing? What's the level of accessibility? How easy is it for a user to get a collection kit in order to do this? Are there support services available? Is the submission form written or is it an electronic platform that can be used? Again, clear expiration dates on your collection kit, and then information regarding the handling, the storage, and the shipping of the samples if they will be tested off-site. One thing that I was thinking about as I envisioned this presentation is that timed reminders would honestly be very helpful. From the time that an organization or a vendor ships out a self-collection kit, can the clock be started at that point, and can reminders be sent via telephone or app or text message or email to remind the user that these are the time frames that you need to get these things in? Next slide, please. So we're now at the analytical portion of testing, and there are two different options as was previously discussed. The testing can be performed by a laboratory, a high complexity testing laboratory, or the testing can be performed at home. If performed in a lab, is the method FDA approved or not? Have they accurately established accuracy, precision, reportable range, and reference range? Since most of these will be used off-label, they will additionally need to do analytical sensitivity and specificity. What's the reporting structure? Once the result is available, do you report to the preventionist? Do you report to the customer? Do you report to the health department? And it's a mix of maybe all of the above. What are the quality indicators that are in place? Have you created things that you can observe directly to determine whether or not the system is functioning as expected? I referenced an example earlier about time points. How frequently are you having to reject samples, and what's the reason? If you find that you're monitoring or you have a quality indicator that indicates you are suddenly rejecting more samples than your normal baseline, that's something to look into and follow up on, because there may be training or resources available that can be given to the customer, to the users, or even to the company that's manufacturing the test or the collection kits for improvement purposes. And finally, again, rejection criteria. At home testing, it will be essential to have training instructions, potentially a video. How easy is it to use? Storage conditions for the device, clearly labeled expiration dates as well. Is the interpretation simple to perform if at home testing is done? Will they need assistance? The prevalence of disease needs to be considered as well, because this will have an impact on the quality of the test results that you may obtain. Next slide, please. Considerations for interpretation and reporting. I'd like to just say that how results are handled after testing, of course, can also impact the action taken in the form of treatment and prevention strategies. So when considering interpretation and reporting, are the instructions clear? Are there pictures that can be used, whether or not they can be read by people who may be illiterate? Those are the types of things you have to begin thinking about when you remove the clinician or you've removed the laboratory from the process. It puts the onus of understanding and being able to accurately perform interpretation and reporting on the user. And so it's important for it to be as simple as possible. Is there a video tutorial? Can the user upload pictures for result interpretation? Is resulting a digital process or is it a manual process? And are the HIPAA requirements for privacy and protection of health information being followed? If you have a digital reporting process that maybe goes through an app, has that app been tested to ensure HIPAA compliance? And then how will you handle follow-up with the clinician? There are lots of different things that can impact the testing again, but follow-up with the clinician is essential, particularly when you have a positive result or a negative result in symptoms. Next slide, please. So things to ponder. I've asked a lot of questions, and the truth of the matter is that here in Virginia, we do not perform, at the State Public Health Laboratory, to clarify, we do not perform any self-collection and testing on site. And so these aren't things that are specifically related to the processes at our laboratory here, but they are things that can be considered when you're trying to make a decision on the best method to use. If you cannot verify or validate all parts of the kit from collection to result reporting, can you validate each piece individually with a pilot study? Can you test out the shipping process from the vendor or from your site of the collection kit to the user? Can you test the actual collection of the sample and determine the quality of the sample? Can you test the shipping process back to the laboratory if this will be laboratory performed testing? And then can you also test out the reporting? Can you pilot studies that will use people to read the instructions and evaluate whether they can get the right results just based on the information that they have been given? It's important to remember that sometimes that collection kits that improve quality will sometimes conflict with safety. And one example is molecular transport media. So MTM is a great media that helps to stabilize a sample and preserve its integrity prior to collection. However, MTM media is made with a host of hazardous chemicals. And if you are sending these things home to your user to use and collect, you'll always want to consider safety. Could vendors use surveys prior to kit shipment to reinforce some of the more critical quality parameters? So prior to distributing a kit to a user, can we ensure with a survey that the correct kits were ordered, that the user understands the shipping conditions or they've been explained to them, that they understand how to store the kit and understand how to use it or perform the reporting pieces prior to sending the kit out? Could a reimbursement of fees be considered if patients follow up with the clinician as a way to incentivize follow-up? And then finally, could integration of quality monitors be helpful in identifying trends that could impact the overall quality of testing? Are you seeing gaps in transport times? Are you seeing that we sent out 100 kits, but we're only getting 20% of them back? Investigate why things like that are happening or work with your vendors to do so. Are you evaluating test rejections? If we send out 100 kits and we now have to reject half of them, what are the reasons why? Are there opportunities that exist to improve the quality? Next slide. These next few slides are some terms that I referred to in the presentation. Certification and accreditation, we talked about with CLIA and CAP. Complexity, since these are going to be off-label usage of FDA-approved tests, they're considered FDA tests, and therefore they cannot be performed in a waived setting or a moderate complexity setting. It is required that they are performed in a high complexity setting. We talked about HIPAA and protection of patient information and laboratory developed tests. Next slide, please. We talked about quality indicators, clinical laboratory improvement amendments, and CAP. Next slide, please. The next few slides are just references that I've used to perform to conduct this particular presentation, and there are about 3 slides here. So I think this is the end of my presentation, and next up we will have Jenny McFarland, who is the Prevention Manager for the Texas Department of State and Health Services. Thank you very much.
Thank you so much, Dr. Freeman. That was really incredible. And I think back to our work in getting this implemented back, or starting to investigate how to get our project implemented in Texas back in April. If we had Dr. Freeman's knowledge and skills in her presentation, I think that we would have been able to proceed a little bit more quickly and also not as naively. I'm Jenny McFarland. Good afternoon, everybody. I am the manager of the Texas Department of State Health Services Prevention Program. First of all, I have to thank NASDAD and our partners, Dr. Gaynor and Dr. Randall, with your invitation to participate. I also want to acknowledge that we are late to the game of adopting self-testing as a strategy. Our partners in Virginia and in Arizona started this a few years ago, and we really admired their work. And it wasn't until COVID that we really were forced into a situation. Next slide, please, Kendra. Thank you. Okay, and you can keep going. I do want to acknowledge that also that this training and our guidance and its interim guidance was created by a group of our staff. Some of the staff that are participating in this webinar are our STD nurse consultant, Pam Matthey, our subject matter expert around test technology, Isabel Clark, and the manager of our public health follow-up program, Karen Sarita. So you can just go to the next slide, please. And also I want to acknowledge Terry Moore and Jonathan Poe, who are epidemiologists that work with us to help us gather our data. But really and truly, bringing this interim guidance was all of the prevention program and the public health follow-up program coming together. Next slide. So what does it mean to provide HIV and STD screening in Texas? As you can see, we're quite a large and diverse state. The red stars indicate high morbidity areas. So these are the big 5 cities. And then the yellow stars are the moderate morbidity areas. And then we have the green stars are our low morbidity areas. And then we also have low morbidity areas that are pretty much where you see Kentucky, that state. We've got a lot of, they talk about how there are more cows in that area than there are people. But so the thing is that what we recognize is that providing this type of service in such a large state with such diverse populations, multiple high prevalence areas, and like Dr. Freeman said earlier, that does affect the test when it is being performed. Back in the day, we would hear folks talk about the positive predictive value of a test. And when I'm doing a test in a low morbidity area, how that affects the sensitivity and specificity of the test because of the morbidity in the area. And understanding resources, how does this impact how we distribute resources in our state? Next slide, please. So our current testing portfolio includes supporting HIV screening and STD screening all around the state at our regional and local health departments in their sexual health clinics, which are doing some PrEP and NPEP services, along with the public health follow-up. So that's the disease investigation activities, the partner services activities. Another part of our testing portfolio for our state is our HIV prevention programs. We have programs that are focus testing based, so they are according to their area, their HIV service delivery area. What are the populations with the greatest vulnerabilities of acquiring HIV? And then we also support routine screening in our state as well. So that is the good old-fashioned 2006 CDC recommendations on routine screening in healthcare settings. And so we've been implementing and really trying to push this activity since 2006. We also are supporting sexual health clinics performing PrEP and NPEP activities. Now, so when we were looking at adopting this as a strategy to our overall portfolio, we wanted to look at it across the board and how it would impact or making it available to all of our partners who are practicing these different strategies. Next slide, please. So the impetus was obviously COVID. Like many of you all, areas of our state were completely shut down. It depended on the local jurisdictions. Some areas of the state could go out and travel and continue testing, but most areas, especially our major metropolitan areas and our moderate morbidity areas, those programs were pretty much stopped in their tracks. And as many of our programs continue, especially our health departments, they are stressed with performing COVID-related activities. We also started getting questions. May I use my funding to purchase a self-administered test? So as Dr. Friedman spoke about earlier, the OraQuit HIV test. Our community planning group reached out to us, and has been for a while, honestly, and saying, you know, are you guys doing this yet? Are you doing it yet? And then as we adopted the ending the epidemic activities and looking at the other fast track cities and the other strategies in our own plan for our state of diagnosis and full diagnosis, we realized we need to get out of the Stone Age and adopt, start looking at how we can provide interim guidance and adopt this as a strategy. But our hesitations were our own capacity. Unlike other jurisdictions, we do not have the capacity for a person or a program to run the negotiations of distributing test kits all around the state, or facilitating the complex activities that you heard Dr. Freeman talk about earlier, of identifying a self-collection kit and then identifying a laboratory that is able to process those kits. So capacity was a key, procurement when it comes to providing the funding, the data collection. How are we going to collect the data? What tool do we have to collect the data regarding the testing that's performed? Along with disease reporting. In our state, all HIV tests are reportable, including preliminary positives, and all other positives are reportable, including quantitative and qualitative. Viral tests are reportable, even if it is non-reactive. So we wanted to make sure that we had information to share with the community, that if you are going to do a self-administered test, that that preliminary positive is reportable. We also were concerned about how are we going to make sure that supplemental testing is available to individuals, and who would be the eligible populations. Since we are such a large state and resources are quite, not as abundant as they have been in the past, how are we going to prioritize and make sure that we break down those barriers for people who need testing the most get testing? And also back to the idea of this is adding to our portfolio, because we know, as what was mentioned earlier, for identifying early infections, blood is best. If I can get a tube of blood on someone, along with a tube for syphilis testing and HCV, that really does further our ability for early diagnosis. So in order for us to do it, we realized we had to elicit input from the community. We had a program that had already started with their own funding to work on this, and we got their input. We ran our guidance and our interim guidance through our programs and with our health departments to gain their input on if what we were asking were creating more barriers, because we didn't want to create more barriers. So we came up with some interim guidance, and if you'll go to the next slide, please. We made some commitments. So here as I said earlier, we decided that we really wanted to make sure that our programs were offered this opportunity across the board. We have some interim guidance, and the web link is attached to this presentation. And we did do a web-based training. And we also made a commitment to our programs to review and provide input on their policies and their procedures, and also to help facilitate peer-to-peer support. So if we had a program that wanted to get this started, we made a commitment to our programs to put them in touch with other like jurisdictions. So not just like a big program in Austin to talk to a small program in Corpus Christi. That's not, that may not be relatable. So we've made a commitment to pair people with similar size of programming. We also, feel like it's very important as we are just learning so much from Dr. Freeman about how complex the process is for validation and FDA approval, et cetera, you know, we want to make sure that people understand and offer the training to build their capacity and knowledge around laboratory testing and the markers, you know, making sure they understand what is this test looking for and what do the supplemental tests look for. So we made a commitment to provide that ongoing training. And also, like I said earlier, prioritizing our populations with the greatest vulnerabilities. And then with the 2020-10 funding, we realized that we had an opportunity. Let's try out our statewide condom distribution program that we support called Texas Wears Condoms. Let's talk with them because they've been so successful of gathering data, distributing condoms, following up with providers, and evaluating their practice. Let's reach out to them and see whether or not they can pilot a project of distributing self-administered HIV tests. Next slide. So this is a really crazy busy slide, but this is what I mean about the populations with the greatest vulnerabilities. And so when we reached out to the programs that we support, it pretty much was when you create your policies and procedures and your protocols, you've got to make sure, we want to make sure that you are prioritizing of providing these services to the populations within your area that are most vulnerable. So when I'm in Dallas, my priority populations in Dallas, and this is all from our epi and surveillance data, including prevalence and new diagnosis. So we pulled all this together and we wanted to make sure that folks were making their services available to the specific population and really assessing, okay, if I'm in an area in Fort Worth, what does it look like when it comes to my Hispanic or my Latinx MSM? Am I making sure that I have materials in English and in Spanish? So things like that. This is why this is a huge slide. It's kind of crazy looking, but I want to make sure you understand that we recognize that this type of service and provision of the test kits are really catering to the population within your local area. Next slide. So we actually also have had a policy on the books with our programs pretty much saying that if you're going to be funded by us to do testing, you've got to use blood. Because we recognized, you know, years ago that we did not want to miss full diagnosis. We didn't want to miss that early diagnosis. So when programs were submitting their checklist, their policies and procedures, we would offer them a waiver for their blood sample collection requirement. And so, like I said earlier, we posted our guidance and we did the webinar and we did the training. Next slide. So again, you've heard us talk about this already. The purpose is to increase and maintain any screening out in the field, because we saw everybody shutting their doors. We saw people getting pulled to provide other activities. We did make a commitment that we cannot endorse any specific test technology, manufacturer, or laboratory. And we also made sure that we emphasized cater your services to, you know, the programs in your area, but you may not open and change the test kits. Okay, I know I've got to get it in gear and get going quickly. Next slide, please. So these are some things that we looked at. We wanted to make sure that they were identifying the population for their area. They were identifying how they were going to pay for the testing. What was the staff time that was going to be required? The postage, things that Dr. Freeman spoke of earlier about inventory, about quality control, how are you going to maintain the confidentiality of your patient population? How are you going to make sure that the patient that you're talking with that's getting the test kit is going to be consenting? How are you going to be shipping it? The Texas heat, the crazy Texas freeze that we had in February. How are you addressing these items and maintaining quality control measures? Next slide, please. Okay, we wanted to make sure they described to us, you know, how they were going to be following up with the test kits and what the results were. Are you going to be offering an incentive for the patient calling you back or contacting you about the test result? How are you going to distribute those incentives, or what we call tangible reinforcements? That's the term that we use. We wanted to make sure that that people had the latest information regarding the supplemental testing activities in their area and the care services activities in their area. Because as you know, many places have shut down, some of them have altered their hours. We want to make sure you have the most up-to-date information. So as you can see, we've been asking a lot from our programs. How are you going to make sure that public health follow-up is in partner services are offered to the patient? What if you can't reach the patient? Thinking through all these steps has been quite intense. Next step, please. Next slide. So what we learned, you know, we are not a centralized state. We are a decentralized state. Our local and regional health departments really had to navigate their own procurement processes. Pam, who I mentioned earlier, had been working with a large health department in one of our large cities and realized that their procurement process for purchasing the self-collection kits was going to be so difficult and actually quite costly. It was going to be far much greater than lab testing. Now, our lab in Austin, our state lab in Austin, has not validated the ability to process the home collection kits either. And then also finding a laboratory that has been validated. As I said a number of times, again, looking to see how our health departments have been really struggling to continue their basic services along with this as an option. We haven't taken it off the table for them. We want to make sure we continue to problem solve with other programs and other health departments of when we've got someone that can get up and going, that they are supported. And then how are we going to collect this data? So for our prevention programs, many of you are familiar with Evaluation Web. We were able to identify a setting within Evaluation Web and instructing our programs to use a setting, home test setting, and identified that setting as a way of reporting their test kit distribution. Now, the other thing that you've got to keep in mind, what we learned was, what if I'm a patient and I've requested 2 test kits and we mail out 2 test kits? Well, I can do 2 test kits, but how do I enter that into Evaluation Web? So one test does not necessarily mean one individual. Next slide, please. So our immediate outcomes through all of this, we've got, including our health departments, about 50 programs that we support all around the state. 9 of them have submitted their checklists and their procedures that we've gone through and approved. And what we've seen is 4 of them have submitted data. So far, they've only distributed that we see from our data, and this is only an Evaluation Web. This is not our data collection with Thesis yet for our STD public health follow-up program. So we haven't been able to look at that data yet. But just our preliminary data for our prevention programs is that they've distributed 94 tests. None of them have been preliminary positive. The good news is that the participants are mostly men who have sex with men, Latinx, Black, and white. We have had them distribute to Black women who have sex with men and Latina women who have had sex with men. Only a few persons who inject drugs. And as of last month, none of our programs have contracted with a self-collection lab or provider. And I can tell you that the Texas Wears Condoms site is now live, and they are using a WebCap survey to determine if someone is eligible to receive the test. Next slide, please. And this is just an overview of what we've seen so far. So we are happy to see that the test kits are going to the populations with great need for testing. And we will continue to track this. Next slide, please. And this is just a picture of Texas Wears Condoms and their at-home test kit. I think that we're going to be learning from them. This is brand new, so this is all in process. Next slide. And thank you very much. What I want to tell you about the future is that, again, we see this as a complement to our testing strategies. We consider that we need, to provide a buffet of options, as we used to always say, with our patient population. We really want to work on reducing barriers, but being realistic. Telehealth has been fantastic when it comes to expanding the ability for providers to visit with patients. Many of us have experienced it ourselves yet, but if I am in a community that does not have high-speed internet and I don't have access to the technology such as a smartphone, am I really and truly making an impact? And so we are really and truly working with our programs to help them explore, how we can reduce those barriers to testing. Thank you.
Thanks so much, Jenny. That was terrific. And what I think we want to do now is use the remainder of our time to have some open question and answers. There are a number of questions that have come in through the chat, and I encourage you to continue to do that. There is one question in the chat that was actually answered directly, but I think it might be worth, well, two questions might be worth saying out loud. One, there's a lot of requests for when will the slides be available, and just to reiterate, those slides and the recording and the toolkit will all be available and posted on NASTAD's website within the next couple of weeks. So we will make those available to you. There was one question that came in related to, I'll just read it. Please clarify if self-collection for CTGC for rectal throat swabs has been approved by FDA. If it's not part of the package insert, each CLIA lab has to do a validation study. And I think I wanted to raise this in part because I think that the understanding about self-collected in a clinical setting, in a so-called clinical setting, versus self-collected in a non-clinical setting, or what we refer to as a home setting for shorthand, might be really useful. And I don't know if Anne, if you want to answer that, or since you answered in the chat, do you want to
Sure.
handle that?
Sure. So the short answer is that there are no FDA approved or cleared methods that include a self-collected sample in a home setting or a non-clinical setting. So the GCCT NATs that are currently FDA cleared, some of them, I don't know all the package inserts by heart, but some of them do include a self-collected vaginal sample in a clinical setting. So there is specific wording in the instructions for use or the package insert for some of the GC NATs that a self-collected vaginal sample is acceptable, but it is in a clinical setting. So there is no cleared assay that includes a home collected or a collected specimen in a home or non-clinical setting on an FDA cleared method. So yes, if you are interested in testing those samples, or your laboratory is going to receive them, there needs to be a validation in order to test those samples. I think that's the answer to that.
A question related to Texas's experience. Jenny, you indicated that you've seen roughly 54 tests come in, at least based on preliminary data. And I'm wondering if you can comment on whether you expected more or less, or whether you expected the populations that you are seeing, if you had different expectations around that. A comment came in from California about the majority of home test kits are being used by Latino gay MSM. So if you could just speak to your expectations and experience, I think that would be helpful.
Oh, thank you. Yeah, actually, I was surprised when we pulled the data from our programs. I think it was 94. Can we go back a couple slides? Goodness, everything's going by so quickly. Isn't that awful that I can't even remember my own numbers? Yeah, I was surprised, but you know, one thing for jurisdictions taking this on, keep in mind that if you go through this process, what is your staff's time? What is the impact going to be on your staff's time of reviewing the protocols, reviewing the policies, reviewing the procedures, and then giving approval to your sites that will be distributing? Because I can tell you that we tried to make it a priority, but with everyone, including our own staff, and I'm sure many of the other jurisdictions, well, everyone being impacted by us being pulled in different directions, that it did at times take our staff a little bit of longer than we would have hoped to give feedback. So yes, I did expect more data, more tests to be distributed. Ramp up takes a while. When we looked at the time frame, one of our programs had many distributed in June, but very few the rest of the year. So we'll be tracking this. It's going to be interesting, and we're going to be getting back with folks to get their input. What was going on at that time? Does that make sense?
It does. Thank you, Jenny. Another question.
I'm sorry. I am really pleased to see that the population's accessing the test. I think that is something that when we see that so many Latino men who have sex with men are getting tested, that makes, that is that's good news, and we want to learn what's making it so successful. Who is the program that's doing the majority of the distribution? And what is making it so successful, so that we can take that information and share it to learn with other, to distribute it. This is diffusion of innovation.
In real time. Marilyn, there was a question that came in about the frequency of verification testing.
Yes, can you hear me?
Yes.
Yep.
So verification testing is actually only required once prior to usage. However, there's a caveat. If anything changes in the package insert that would affect the performance of the test potentially, you would need to do it again. So examples would include a new sample type was added to what was FDA approved, or sometimes the manufacturers like to change the reagents that are being used in a test kit. So if you get notification that that has occurred, you also need to validate. Another example would be the test system, or maybe the device that it's run on. If that's changing, then you have to validate that as well. And those are just a few examples.
Not seeing additional questions coming into the chat. We have a few more minutes. And I have one question that I'll put to any of the laboratorians or laboratory adjacent people on the call. for a health department and or a public health laboratory, you know, is this moment an opportunity to build capacity that will extend beyond the pandemic and possibly have other applications? I'm aware that a lot of us have recently had some increases in funding for, you know, COVID-related purchases, either for laboratory or expanding program activities. And I'm just wondering if any of our presenters or subject matter experts can comment upon whether they are seizing the moment, if you will, and what recommendations they might give to jurisdictions about leveraging COVID. Frankly, never waste a crisis, right?
Absolutely. This is Marilyn. I will say that this is absolutely an opportunity to expand at home and self-collection testing. What I think we really need to begin thinking about are the risk and the benefit. And understanding very clear what the risks are and whether or not they can be effectively mitigated. And if the answer is yes, then I think this is a great opportunity to try to extend self-collection, self-testing out into the normal population so that this becomes something routine. But I do think there are cases when risk can't be mitigated enough. And we have to make clear decisions on when those cases exist.
Jenny, you have a thought? I can see it. It wants to get out.
Yeah, I mean, I think that's a really great question. And, you know, I was reminded by our programs just recently that, you know, we are still pushing for our programs around our state, especially our emergency centers, to adopt routine screening as a standard of care. And we have a wonderful story where, and Isabel reminded me of this recently, that, you know, a woman goes into an emergency center afraid she has COVID because she has flu-like symptoms. Thank goodness that program and that emergency center had adopted and has established routine screening as a standard care. They tested her for COVID, she was negative. That's it, tested for her for HIV. She was living with HIV. So I think this leverage idea is very important, but we think about leverage across the board. Not only, yes, using leverage to promote self-testing and self-collection for testing, but also how can we leverage, where is it with our programs around the state and especially in our state that still have not adopted routine screening, and us constantly learning from our programs about accessibility to testing, whether it is by self-collection, self-administering, or making your services more accessible to your communities.
We have time, I think, to squeeze in one final question. And there is a question that came in the chat that relates to some of the third-party laboratories, meaning you would contract with a laboratory. And the core of the question is, are any of the tests done by these laboratories considered CLIA waived or validated? Can we have either Marilyn or Ann address the waived and validated and the third-party tests?
So I'll address the CLIA waived status. At this point, there are 0 tests, or well, actually 1, I guess technically the ORQUIC, but there are 0 tests otherwise that are considered CLIA waived.
All right. We are at the very bottom of the hour. We have just another few seconds to go. I want to thank my colleagues from Virginia, from Texas, from CDC, and of course from APHL for participating in organizing and delivering this webinar, and for the toolkit. Contact information for all of us in some fashion. Oh my Lord, we're all on that slide. You can find all of us. There is information about capacity building and technical assistance, which is also going to be provided to you in the chat function. As I mentioned earlier, the recording, the slides, the toolkit, all of the questions, we are going to write up and post those. Send those out, I think, to participants and post them on the website for NASTAD in the next couple of weeks. And I thank you all for joining us, and have a fantastic afternoon.